Okay. Hello, everyone. My name is Charlie, International Marketing Manager from Research Medical. So now we are very honored and proud to invite Professor Paul Kessler and Professor Alan Delbas to share with us their latest research. So before we start, let me introduce both of them. So Professor Kessler is post-certificate anesthesiologist, critical care medicine, pain therapy, and emergency medicine, and was awarded professorship in anesthesia in 1998. He received his specialty training in anesthesiology at the John Wolfgang Goethe University, Frankfurt, Germany. From 2003 to January 2020, he was chair of the Department of Anesthesiology, Intensive Care Medicine, and Pain Medicine of the Orthopedic University Clinic in Frankfurt, Germany. Since February 2020, Professor Kessler is vice chairman of the Clinic of Anesthesiology, Intensive Care Medicine, and Pain Therapy of the University Hospital Frankfurt. His clinical expertise focuses on regional anesthesia. Paul has co-authored over 100 peer-reviewed papers, review articles, case reports, and book chapters. Paul Kessler is a member of many national and international societies of anesthesia. From 2009 to 2014. He was chairman of the German Task Force of Regional Anesthesia. From 2009 to 2013, he was board member of the ASRA, and from 2014 to 2018, he was a German zone representative in the ASRA Council. So currently, he is the chair of the ASRA cadaver workshops. So let me introduce Professor Alan Delbas. He is an anesthesiologist working in a private hospital, Toulouse, France. So he has a team of 10 anesthesiologists working in orthopedic survey with 25 orthopedic surgeons. Currently, he has 25,000 orthopedic procedures per year. So 80% with regional anesthesia, 70% in ambulatory survey. So his principal topic of including regional anesthesia, peripheral nerve blocks, orthopedic surgery, post-operative pain, simulation for training, robotics in ultrasound-guided peripheral nerve blocks. So he has many participations in scientific societies. From 2001 to 2020, he is a council member of the National French Society of Anesthesia and ICU. So from 2017 to 2020, he is the president of European Society of Regional Anesthesia and Pain Therapy. During his president time, thanks to his great contribution, ASRA members rise from 3,000 to 5,000 globally. So also he's chair of some scientific committee of the European Society of Regional Anesthesia 2021. So he has also many books or multimedia DVD in first author. For example, like peripheral nerve blocks, ultrasound-guided nerve blocks, this is in French. So also he has numerous international publications on regional anesthesia, and also numerous participation to international congress. He was awarded recognition of education in regional anesthesia award ASRA Berlin in regional anesthesia during the COVID-19 pandemic. So let's welcome.
I hope you can see now my presentation. First of all, I would like to thank Visonic Company for organizing this webinar series, Meet with Experts in Regional Anesthesia, and for inviting me. My talk today is role of regional anesthesia during the COVID-19 pandemic. This is my disclosure. I have got honoraria from different companies, but this will not influence my presentation of today. Here you can see the topics I'm going to talk about in the next 30-40 minutes. A few actual data on COVID-19 pandemic, the situation of health co-workers during the pandemic, what is the role of anesthesia in this situation, and I will concentrate and focus on regional anesthesia and safety aspects in these times, and finally I will have a short summary. As you know, since the coronavirus was first described in the end of 2019, this virus, I think, has changed the whole world. Our whole situation, our personal situation, social situation, and also our professional life. Up to now, nearly 150 million people suffer or suffered from COVID-19 infection, and more than 3 million people have already died from COVID-19. And here, this is a picture published in The Guardian last year, showing the pictures of UK health co-workers who have died from COVID-19. And in the meantime, you see here data from the January of 2021 from the United States. And in the meantime, I think several 10,000 health co-workers have died from COVID-19. And the question is, why did they have to die from COVID-19? And I think one of the reasons is that health co-workers are in close contact to COVID patients, and they have to a higher proportion of the health co-workers are infected by COVID patients compared to the normal population. And I think there are three major reasons which contributes to the increased risk of health co-workers. The first one is that we sometimes are confronted with patients, with asymptomatic infected patients with an unknown infection status. As you know, the incubation period lasted from 4 to 5 days up to 14 days. And during this time, the people has to be in quarantine. And the problem is that during the incubation period, you should not have symptoms. So some of the patients are without any symptoms. And this is the problem when you are treating patients during this incubation period. And for this reason, it's absolutely mandatory that you have an infection control of every patient in your hospital. In our hospital, it is the situation for every patient who is scheduled for an operation, if this is an elective operation or is it an urgent operation or an emergency operation, for every patient, we require a COVID test. In former times, we used a rapid antigen test with the result within 15 minutes. This was very nice. But as you know, the sensitivity of this antigen test is not very high, between 70 to 90%. And I think for more than 1 year, we require in our hospital for every patient scheduled for operation, we require a PCR test. But the duration of the PCR test until we have the result lasts 4 to 5 hours. And during this time, we have to treat a patient under investigation as a patient which is COVID positive. The second major reason, I think, is that the healthcare workers don't wear adequate personal protective equipment. We know that the transmission of respiratory viral infections are by 3 different routes: by contact, droplets, and by aerosols. And depending on the transmission route, you have to wear different personal protective. Not so dangerous are droplets. Droplets are heavier, and due to gravity, they drop down, and they can spread only in a distance when you exceed droplets up to 2 meters. So the questions now, major questions is, how is COVID-19 infection now transmitted? By which route? And there is a common sense among experts that is mainly by contact and droplets. And contact and droplets requires this personal protective equipment. You have to wear resistant gowns, gloves, and for droplets protections, you have to wear a face shield or goggles and a fluid-resistant face mask. That means you have to wear a surgical face mask. You don't have to wear an FFP2 or 3 mask because this is only required when an infection, a viral infection, is transmitted by aerosols. Here, this picture demonstrates you the beneficial effect of the face shield. This is a study we made here in Frankfurt. And you see when someone is coughing, you see the droplets formation on the face shield, visible made here by fluorescent dye. The last thing, why healthcare workers are confronted to an increased risk of COVID is because we are sometimes, especially anesthesiologists, we are involved in aerosol-generating procedures such as general anesthesia. Normally, when the patient is intubated, you have a closed circle, but up to there are different other procedures such as tracheal intubation, extubation, non-invasive ventilation, patient with tracheostomy or with a supraglottic airway, with a laryngeal mask airway. These are all together aerosol-generating procedures and very dangerous. And during these procedures, it's absolutely recommended that you increase your protective clothing. That means you have to wear during these procedures at least an FFP2, better an FFP3 mask in addition to your face shield. We know from former studies that the risk of transmission of a respiratory viral infection is 6.6 times greater during intubation compared to not exposed to intubation. And we also have newer data from last year showing among 2,000 healthcare workers that every 10th healthcare workers involved in tracheal intubation was infected with COVID-19 from the patient. So how can we manage or reduce aerosol-generating procedures for anesthesiologists? First of all, we can make general anesthesia safer. There are several options. For example, we should liberally use video laryngoscopy. Here on the left-hand side, you'll see the conventional intubation, and you'll see the close distance between the anesthesiologist and the patient. If you use a video laryngoscope with an integrated monitor, you see the distance will be the same. The only benefit you will have with video laryngoscopes is if you use an external monitor, then you can see the distance between the face of the anesthesiologist and the patient is larger. And this is a safer method to intubate the patients. The other option is you can use so-called intubation box. There are several different intubation boxes created for COVID-19 patients, and you can see here one, and you can separate the head of the patient where you do the intubation from the environment. Here, this is a protective dome created in Frankfurt, and you can see here how you can use it for intubation of a patient. But lately, all these protective boxes are under discussions because people are arguing during the intubation, this is a very safe situation, but during the intubation, you collect all the virus under this intubation box, and if you remove the intubation box after the intubation, you will release a whole amount of virus into surroundings. So that is called a secondary aerosolization. This is an ongoing discussion, and we don't know is it true or is it not true, and is it dangerous for anesthesiologists or not. I think the best option to reduce aerosol-generating procedures is to use regional anesthesia, neuraxial blocks, and peripheral nerve blocks. And this is also a common publication from the American Society of Regional Anesthesia and the European Society that regional procedures are not considered aerosol generating, so there is no necessary for use FFP3 masks. This is the recommendation of ASRA and ESRA. But Whether COVID-19 is transmitted only by droplets and not maybe also by aerosols, this is a discussion among experts. You can see here a study showing what is produced during normal breathing, during loud talking, coughing, and sneezing. And you can see there are not only droplets produced, but there are only aerosols produced during all these procedures. And so we can assume that also in a spontaneous breathing patients, maybe there are some aerosols transmitted, and this could be a risk for the anesthesiologist. And here you can see the recommendations of the Canadian Society of Anesthesiologists, and they assume that even a normal breathing patient in regional anesthesia needs the protection which is necessary for aerosol protection. That means anesthesiologists should wear a FFP2 or 3 mask. And here, and this is a question, which level of protection is necessary? You see here the recommendation of ASRA. For the face, you need a surgical face mask with the face shield. And here, this is what we are doing in our hospital and also in Germany, FFP2 or 3 mask with a face shield. And this is the recommendation of the Robert Koch Institute, and the Robert Koch Institute is our National Institute of Disease Control and Prevention, and they recommend these protections. Nevertheless, even if you do some blocks I think are at higher risk of transmission of virus. When you do blocks close to the head or the neck of the patient, that means if you do an interscalene block or if you do a infra or supraclavicular block, it's considered better to wear, to use the protections for aerosols. That means you should wear an FFP2 or 3 mask. If you change a spontaneous breathing patient to an intubation, you also should wear the FFP3 mask. And also if a patient under regional anesthesia needs a high flow oxygen, it's also better to increase the protection level of the anesthesiologist. But overall, under the bottom, we can say spontaneous breathing patient under regional anesthesia produces less aerosols compared to general anesthesia, and there's a lower risk of transmission for the anesthesiologist. But we know there are a lot of many other benefits of regional anesthesia compared to general anesthesia, but these data are not coming from infected patients. And I will show you some details. Especially for orthopedic or for trauma surgeries, we can choose if we want to give the patient a regional block or if we want to use a general anesthesia. And especially for the major hip and knee surgery, we have a lot of data, as you can see here, epidemiological data, and all these data show that neuraxial anesthesia lowers the risk of mortality, hospital stay, and ICU admission. And if you use neuraxial blocks, you can reduce the risk of pulmonary complications compared to general anesthesia. And of course, this is also a very important issue. You can reduce the hospital stay, and by this way, you can reduce the cost because we can see less complications, less admissions to the ICU, and people after spinal anesthesia for hip surgery need less ventilator support. This could be shown not only for elective hip or knee replacement, but also for hip fracture patients. You can see here a systemography and a meta-analysis. The 30 days mortality was not different, but the in-hospital mortality and the post-operative comorbidity was lower, so that the author stated that neuraxial anesthesia improves hip fracture outcome in elderly patients. So we can see when we use regional anesthesia for some operations compared to general anesthesia, we can reduce the resource consumption. And this is also bring the patients directly from the OR to the normal COVID-19 ward. If the patient have a general anesthesia, the patient in our hospital has to stay in the operation room until he is ready. He has the readiness for the normal ward. And that means during this time, we cannot use the operation for other operations. And even if the patient has a general anesthesia and we do a block for post-operative regional anesthesia, this is an improvement because we know, for example, if we have a thoracic surgery, a major thoracic surgery or major abdominal surgery, and we do a thoracic epidurals, we don't need as much as opioids after the operation, and that means the patient can be transferred from the OR earlier to the IMC, ICU, or to the normal ward. But there is a big difference compared to normal patients when we use anesthesia in COVID patients. Usually, our major goal when we can compare, for example, for orthopedic surgery, we can choose between regional and general anesthesia. Our indication is major driven by the situation of the patient. How is the medical situation? But in COVID times, we also have to ask us what is the best for the anesthesiologist, not only what is the best for the patient, but also what is the best for the anesthesiologist and what is best for resource utilization. You can see this is a complete change in our anesthesia praxis. And regional anesthesia in COVID-19 patients is safer for healthcare workers. You can save financial costs and personal protective equipment. This is the recommendations or the statements from the ASRS recommendations. As I have shown you, I think we should also increase the level of protection, even if we have a regional anesthesia and a spontaneously breathing patient. So I think this is no advantage compared to general anesthesia, because in our hospital, we have the same protective level when we use a regional or general anesthesia, but we can increase ICU resources and we can lower the health system burdens. But overall, we have to say we have no evidence-based data on this. But nevertheless, the common recommendation of both big societies is that regional anesthesia is the preferred method over general anesthesia, and you should regional anesthesia always use when it's possible. So how should we perform regional anesthesia in COVID patients? You can see here how we do it in our hospital. We usually do the procedure not in the induction room. We do everything in the operation room. You can see we cover the ultrasound machine in plastic, with plastic, also the ultrasound probe. All the drugs are packed in plastic bags, and we have no more paper for documentation. We have here mobile documentation. We used a mobile system with an iPad, which is also packed in plastic. The patient, of course, has always to wear a face mask when he is transported in the operation room. We no give nasal bronchs because we think that we increase the aerosolization, and this is no good. We use a tight-fitting oxygen mask, and if the patient and the surgical face mask, we place below the oxygen face mask, or we place the mask over the oxygen face mask. How should we manage and conduct regional anesthesia? You should wait before you start the operation that the block is well working. Otherwise, you have an emergency. You have to do an emergency intubation, and this is not so good. And this means you should allow extra onset time until the block is working. And you should not use deep sedation for the patient because this requires oxygen and probably also the general anesthesia. For new Raxel procedures, spinal is not contraindicated in COVID-positive patients. There's no dose adjustments, but you have to think about that in severe cases, can occur a thrombocytopenia, which can be a contraindication for new Raxel blocks. And you must be aware that the cerebral major issue, because this is something what we are familiar with if we do spinals. Here you can see how we do a spinal in COVID-19 patient at our hospital. It's the same. I think the procedure is the same, except of that you have here different closes. And again, also for epidurals, it's the same procedure, but in addition, you have to veer over the water resistance gone. You have to veer the sterile gone because you have to do a Kessler technique. But except of this, it is all the same. And we have several case reports in the literature regarding spinals and epidurals that it was be used safely in COVID-19 patients. We also have here observational study from Wuhan in China, including 49 female COVID patients. Mainly of them had a cesarean section and the spinal was uneventful. And most of these patients had mild COVID-19 pneumonia, and the pneumonia have not worsened during the spinals, and all the babies also had no transmission of infection of the mothers. There is but one major issue you should think of, and which could be a problem, is the post-dural puncture headache. I think this is not a big issue, a major issue when you have a puncture headache following spinals, because for spinals you had small needles, and usually this conservative therapy is sufficient. But if you have a puncture with a 17 or 18 gauge epidural needle, probably this conservative therapy is not enough, and usually you would use a patient epidural blood patch, but and this has a success rate of 80 to 90%. But in COVID-19 patients, you must be aware that you will inject viremic blood into the patient, into the epidural space, and we have no data on this. Is it safe or not? And if there is an untreated pain in the patient and the patient required for this, you have to tell them especially the pros and cons of the epidural blood patch. And you should always have the written consent for the patient if you are going to do an epidural blood patch in a COVID-19 patients. What about peripheral nerve blocks for anesthesia in COVID-19 patients? You should be very experienced so that you have a high success rate, and there's no need to convert to general anesthesia. Here, some examples for an infraclavicular block in the COVID-19 positive patients, or here, this is a popliteal block, a sciatic block in patient in the prone position, with a patient in prone position. And here, an interscalene block. The block performance is always the same, except of the fact that you have to wear the personal protective equipment. You should always choose the right block for the right surgery. Otherwise, you have the risk of conversion to general anesthesia. And in this context, you have to remember the very popular truncal blocks right now. These are only analgesic blocks you have to keep in mind, and no anesthetic blocks. You can add it to general anesthesia, but usually you cannot do, except of very minor trunk procedures, you cannot use it for anesthesia except of the perivertebral block. As I told you before, you should test the block before you start with your surgery, and you should allow extra onset time for block success. If you do a peripheral nerve block, you should always do it with ultrasound. We have now many comparative data with nerve stimulation, and we knew when we use ultrasound, we have a higher success rate, less needle passes, a faster block onset. And of course, we can reduce the risk of local anesthetic systemic toxicity for several reasons. One of the major reasons is we can avoid any vessel punctures because we can see vessel on the way when we advance the needle. And the major advantage in my eyes is that we can reduce the amount of local anesthetics. For example, for nerve stimulation, you need 40 to 50 ml of local anesthetic for an interscalene block. And if you do it by ultrasound, you only need to use between 8 to 10 ml to have a well-working interscalene block. And of course, you should use Interscalene block, but you have to modify your Interscalene block. You should have to use a low volume to reduce the risk of a phrenic nerve palsy. You should use a posterior injection, an interfacial injection. You can use other blocks, suprascapular block, and the combination of suprascapular and axillary nerve block, which will never interfere with the phrenic nerve. Or you should use a superior tongue block of C6, reduces the incidence of phrenic nerve palsy. Or you can also do a supraclavicular block, which also blocks is also sufficient for shoulder surgery. If you do surgeries below the shoulder, the upper or lower upper extremity, you should prefer an infraclavicular and an axillary blocks compared to a supraclavicular block, because infraclavicular blocks and axillary blocks will never affect any phrenic nerve. What about perennial additives? Indeed, they can increase the block duration, but you have to keep in mind that except of adrenaline, all of the additives are off-label use. So you have to explain it to the patients. And if you use, for example, dexamethasone, if it has immunosuppressive effects, this can be, usually we also use dexamethasone for therapy of severe COVID-19 patients, but in other patients, probably it has an immunosuppressive effect. And if you will increase the duration, you can use it intravenously. If you use clonidine or dexmedetomidine, the two alpha agonists, you have to keep in mind the side effects, sedation, bradycardia, and hypotension. You should not use large or extensive intraoperative sedation, because this can require any airway manipulation, and this will increase the aerosols. Perennial catheters can also be of beneficial effect. You know the beneficial effect of catheters for many kinds of surgeries. You can decrease the amount of postoperative opioids in these patients, but catheters also have some limitations. First of all, the failure rate can be between 10 to 30%, and there are other minor limitations. When you use catheters, you should give the real indication. I think mainly from very painful procedures, catheters are indicated, and for example, in opioid-dependent patients, and if there is a high opioid demand after the operation, you have to keep in mind that every kind of opioid can impair the respiratory function in COVID-19 patients with pneumonia. If you have catheters, you may increase the visits of the patient postoperatively. And if you have a catheter, I think a well-working continuous infusion is better than an intermittent injection into the catheter, because an intermittent injection requires several visits to the patient. But there are also some limitations, the comorbidities in anticoagulated patients, and probably the several, especially the neuraxor blocks, are not indicated. Peripheral nerve blocks, there are several reports of peripheral nerve blocks in highly anticoagulated patients. When these blocks are done with ultrasound, even in patients with antiplatelet drugs and even with aspirin and with clopidogrel, blocks could be performed very safely. If you have patients with difficult anatomy and there is a high risk of not a well-working block and a high risk of conversion to general anesthesia, probably you also avoid the performance of a regional block, if you can see here, in very obese patients. And we have data on patients with a high BMI that the success rate is lower in these patients, and this would require in COVID-19 patients conversion to general anesthesia and a higher risk of transmission of infections to the anesthesiologists. Here you can see some examples in obese patients. And if patients already need high flow oxygen, probably is the better way to intubate the patients and to have a closed circuit as to perform a regional anesthesia in these patients. These questions has been resolved. We know from former patients with infection that regional anesthesia can be performed safely, but on a case-by-case decision. It should be done only when antimicrobial drugs is already given and had an effect. We should prefer single shots rather than continuous techniques, and we should use, if we use catheters or blocks, more peripheral rather than neuraxial blocks. Here is an example of a male with a knee infection, which was scheduled for an arthrotomy. It was a COVID-19 positive patient with tachycardia, tachypnea, and he had in a lumbar puncture, he has Staphylococcus aureus in his CSF fluid. And the question was what kind of anesthesia, because he had COVID-19 pneumonia. The anesthesiologist won't given a general anesthesia because he's infected cerebrospinal fluid. What about neuraxial anesthesia? Usually it had been contraindicated, but in this case they placed a spinal catheter for the operation so they could titrate the local anesthetics, and it was an uneventful spinal anesthesia. What about pros and cons? If you use spinal blocks for postoperative analgesia in COVID-19 patients, if there are alternative regimens, especially with non-opioids, you should prefer this. But you have to keep in mind, if you have a block, you have an opioid sparing effect, and this can be beneficial in patients suffering from COVID-19 pneumonia. Try to place the block before induction of general anesthesia because the patient can position or reposition themselves. And if you do lower limb blocks, you should keep in mind, you should do blocks which do not impair mobilization. Here an example, if you have a patient for major knee surgery, you have to do a block for the lumbar and for the sciatic block. You have a lot of different blocks you can use. But if you go more distally, you have less muscle weakness. And so the recommendation would be, if you do a block which fulfill the criteria of good analgesia and early mobilization, you have to choose some of the distal blocks in these patients. So I come to my last slide and my summary. The role of regional anesthesia during COVID-19 pandemic, I think it's a very important role. You can reduce aerosol-generating procedures, and this is a safety issue for healthcare workers. But you have to wear the adequate personal protective equipment. I have shown you that I would always recommend the highest safety level, and that means that you should all general anesthesia, or if you do a regional block, you should always wear at least an FFP2 or an FFP3 mask in addition to the face shield. But you can reduce with regional blocks resource consumption. You can bypack, you can transfer the patients directly to the normal ward, or you can bypass the ICU when you do a spinal. You should always do the safest and the most effective block in your COVID-19 patient. And under the bottom, regional anesthesia is not only good for patients, but also good for anesthesiologists. And therefore, the international society is regional anesthesia should be preferred wherever possible in these patients. Thank you very much. And now I'm finished my presentation. I will give now the word to Professor Alain Delon, a good friend of mine. And he, as you have heard before from Charlie, he's an absolute expert and a former president. And I must say, he is the most successful president Ezra ever had, because under his presidency, the number of participants and members is up to more than 6,000. And by this, the Ezra is now the biggest regional anesthesia society worldwide. Alan, please start with your presentation.
Thank you, Paul. Thank you also for this honor to invite me. Maybe you should stop your presentation. Okay. So that's okay?
Yes, yes.
Okay, perfect. So I am Dr. Delbos from Toulouse in the south of France, and here is my city. And we will talk about regional anesthesia on ankle and foot surgery. You have to know first that in foot and ankle surgery, most of the innervation of the lower limb is made by the sciatic nerve. And only a small part in the inner part of the ankle and foot is made by saphenous nerve, the terminal branch of the femoral nerve. So, more or less, if you organize a sciatic nerve, you can perform all surgery for foot surgery and a big part of ankle surgery. Just in the small part of the inner part of the ankle, you will have absolutely sure some innervation from saphenous nerve. So the first thing is, what type of surgery would you want to do? Or ankle surgery, or hindfoot surgery, or forefoot and midfoot surgery. The most important thing, in fact, is a tourniquet positioning. You can organize the thigh tourniquet, the leg tourniquet, and ankle tourniquet. So if you organize a leg tourniquet, you should organize a sciatic nerve block and a femoral nerve block. And some surgeons prefer to have a thigh tourniquet even for forefoot surgery. So in case of this situation, it's not the surgery's main importance, it's the tourniquet. In case you organize a leg tourniquet, you can use a sciatic nerve block, of course, and then only a saphenous nerve block, because you don't need to have the analgesia for the tourniquet at the time. And then you can also use an ankle tourniquet for ankle blocks. So first, look at ankle surgery with thigh tourniquet and leg tourniquet. In case of thigh tourniquet, as I told you, you need a femoral nerve block and a sciatic nerve block, and leg tourniquet, a saphenous will be sufficient, and also sciatic nerve. Just I want to show you 2 or 3 things, tips and tricks, because everybody knows the femoral nerve anatomy, femoral nerve block. So I will tell you only 2 or 3 tips and tricks. First, you have to know, you can see my mouse or not in the screen, or you don't see my mouse, just to know. No? So
I can see your mouse. I can see the mouse.
Oh, perfect. So you can observe that most of your blocks will be done at this level, at the bifurcation of the femoral artery in superficial and deep femoral artery. At this level of the bifurcation, sometimes you can inject the local anesthetic on the main nerve, but very often you can observe that the nerve is already divided in its different branches. Just one thing to know, these 2 branches are always the same. Just beside the artery, it is the saphenous nerve and the vastus medialis nerve who run extremely close together all along the femoral artery. Then what could happen? In femoral, you have just one first thing is lateral circumflex artery, which run very often in the nerve. In 50% of cases, the lateral circumflex artery raises the femoral nerve just in the middle of femoral nerve. So avoid it, simply avoid it with the probe, and just beware to this artery because it's extremely frequent. Second thing, you can have also at this level, for example, a femoral nerve with an abnormal location, sometimes in the psoas itself and sometimes far from the artery. This is also something very useful. Then, where do you need to inject? Above, under, or around the artery? As you can observe at this level, in fact, you can see that you have a lot of branches, different branches, and then the local anesthetic will spread in where to inject also. If you inject on the main nerve, beware also for the saphenous nerve. It's on the anterior part and of course in the medial part of the nerve. So beware to have the good injection on the medial part close to the artery. So what happens in fact when you use a femoral nerve block, you will inject, as you know, just beside the different fascia. The first one you know perfectly is the iliacus fascia. Then you will inject, and look at this, just beside the artery, it's exactly saphenous nerve and vastus medialis nerve. If you inject against the main nerve, it will be the saphenous nerve will be on the anterior surface and medial surface. But if you inject a little bit distally, you will obtain this spread of local anesthetic, and beware to inject close to the artery also. So now the second solution, as you know, if you use a tourniquet just below, you don't need to have a femoral nerve, but just only a saphenous nerve. The saphenous nerve can be blocked at the femoral block, I already showed you, at the adductor canal block, and distally also at the ankle in perivenous injection. The most interesting using at the adductor canal is, of course, the interest that adductor canal only reduce quadriceps strength by 8% instead of femoral nerve block who reduced quadriceps strength by 49–50%. So the main interest to organize a saphenous nerve block is to maintain the motor function, particularly of the quadriceps muscle. So as you can see, you can perform this block at any level you need for the saphenous nerve, because in fact, the problem of the adductor canal, the big problem of the adductor canal is in reality the vastus medialis nerve, but for the saphenous nerve, it runs just beside the artery from the femoral area, after the femoral triangle, and then to the adductor canal all along the artery. So it's not a real problem to obtain a saphenous nerve block to inject anywhere you want. The only problem is if you inject proximally, you will have a femoral block, and so a trouble with the quadriceps function. If you inject distally, you will not have any trouble, and so that's the case. If you don't need a tight tourniquet, you can inject also in the adductor canal without any trouble. You will always have a saphenous nerve, because it's a big battle of anatomists in the adductor canal, as you know, but the most of this battle is around the vastus medialis nerve. Everybody accepts the idea that the saphenous nerve is everywhere, every time in the canal, in the adductor canal. So you can block where you want, at the level you want. It's not a problem to obtain a saphenous nerve block. But you need the most often to inject higher in the femoral triangle if you want to obtain the block of the vastus medialis. But look at this. This is the middle of the thigh. You have in the same level the saphenous nerve, and this is the posterior branch of the vastus medialis muscle. And the two nerves, even if they are in separate fascias, even that, they are all together. But distally, you will have only the saphenous nerve. But for ankle and foot surgery, we don't need vastus medialis nerve block. We need only saphenous nerve block. So you can block the saphenous nerve exactly where you want. Femoral, adductor canal block, or distally. The main importance is only to have a sensitive nerve block and not to have a femoral nerve block with of the middle of the thigh, more or less, and look at the sartorius muscle. Put the artery just in the middle of the sartorius muscle, and then you will see a small nerve moving from proximally to distally, move the probe 1 to 2 centimeters, and you will see that in fact, this nerve, this white nerve, will move from 10 to 12 o'clock, moving from distally to proximally and inversely. So it's an easy block, and you will never have any trouble with this block. The main trouble of this block is a possibility, yes or not, for knee surgery to block the vastus medialis nerve. But it's not a problem at all to block the saphenous nerve block. Is an excellent block, a sensitive block without any trouble on quadriceps function to block at the adductor canal. So now you have an ankle surgery. We have performed either a femoral block or either an adductor canal block if you organize the tourniquet at the leg. And now we need to make a sciatic nerve block. In this case, if you organize the tourniquet at the thigh, you should use a subgluteal sciatic nerve block, usually, frequently. But in fact, you can also use a popliteal nerve block. It's not so a big trouble for the tourniquet at the thigh. Just generally, we use a subgluteal sciatic nerve block. You can observe this, no problem at all, simple. And you saw this nerve, very simply to do. Just the discussion will be where to inject. And it will be exactly the same discussion, in fact, for popliteal nerve block. As you can observe also, we have just a small trouble is a division of the nerve already made very often proximally, even at the mid-thigh level. And you can see that you have a separate fascia in between the nerve, very often really proximally. So beware when you organize a sciatic nerve to be sure that the local anesthetic will go around the two portions, the common peroneal nerve and the tibial nerve, even if you organize a block proximally. Distally, it's another discussion, and the most interesting is probably to be sure that when you will move the probe, you will see the local anesthetic following the two nerves in the different space, in the different volume, in common peroneal nerve and tibial nerve in separate spread. This is the most interesting, that prove you are perfect, and you will decrease a lot the one-set time. So where to inject clearly? Before we injected just for a popliteal nerve block. Before we injected just in between the nerve and the muscle. But now we inject properly in the subparaneural component just after the paraneural sheath. But beware not to inject directly in the nerve after an epineurium. And this could be extremely dangerous to inject directly in the fascicles. But just here, just in between, you can inject just subparaneurally. This fascia is extremely easy to see on a cadaver, and Paul probably knows it wonderfully because he does so many cadaver workshops. And you can observe here the paraneurium and the epineurium. It's extremely easy to see in anatomy. It's not an intraneural injection, it's really an extraneural injection, and you can observe here the paraneural sheath. So what's the difference in between? When you inject in popliteal area, you can observe here the injection at this level, just in between the muscle and the nerve. You can see a large injection spread, not circular, not just around the nerve, is the old-fashioned method to inject just beside the nerve. But if you want to obtain a good once at time and a real successful, you need to inject sometime, very often, when you use in this big nerve, most of people inject on 2 times, one anteriorly and one posteriorly, but some other publications show that with only one injection, when you can perfectly see up to the nerve and down to the nerve the spread, it could be okay too. What is the minimum effective local anesthetic volume to organize a popliteal sciatic nerve block using a subparaneal injection is in fact only 9 mL of local anesthetic. It's not a big, remember with neurostimulation, we use it frequently 30 to 40 mL of local anesthetic, and now probably with 15 to 20 maximum mils of local anesthetic, we are very quiet, and more or less in our daily practice, we use always in between 15 to 20 mils of local anesthetic without any trouble. And should we surround the nerve? Not necessarily. The most important is to control the longitudinal spread of the probe, of the local anesthetic, proximally and distally to the probe, because you can see if you obtain a 5 centimeter longitudinal spread, you can be sure of your success block. Now, is it really important to use a peripheral nerve block in ankle surgery? And yes, because as you can observe here, in between spinal anesthesia and peripheral nerve blocks, immediately after the surgery, 3-4 hours at the end of the spinal anesthesia, you can observe that the peripheral nerve block has a very low pain level than spinal anesthesia. Beware a little bit also with the rebound pain after peripheral nerve blocks, and it's the same also for opioid consumption in between spinal anesthesia for 3 hours perfect, but then immediately you have some trouble, and peripheral nerve blocks. Probably for rebound pain, it's extremely important to organize around peripheral nerve blocks, and it's not very often made in publication. Use also, now we use additives, we reduce a lot rebound pain, and we use multimodal analgesia and preventive multimodal analgesia to prevent rebound pain. So, in fact, very often the rebound pain are made on old-fashioned publication, and very often that's why you have a real rebound pain after peripheral nerve block. But now, I think with a new system of multimodal analgesia and longer duration of local anesthetic, this rebound pain begins to reduce. Even if, for example, even if you organize a surgery with only the sciatic block, for example, in ankle ligament, you need always to use a saphenous nerve block, even for only analgesia, because if you don't do that, you will have some pain on the medial part of the ankle. So even if you don't use it, you should add a saphenous block for ankle surgery. Second thing, on function of the type of surgery, for foot surgery and mid-foot surgery, you can organize. Some surgeons wants to use a tie tourniquet over leg tourniquet, and some accepts to use ankle tourniquet. In fact, always the same idea, even for foot and mid-foot surgery, if you use a tie tourniquet, you should use a femoral block and a sciatic block. If you use a leg tourniquet, you should use a sciatic nerve block, popliteal or subgluteal, doesn't matter, and a saphenous block if you don't want, instead of femoral block, if you don't want to have trouble with the quadriceps muscle function. But if you accept to use an ankle tourniquet for forefoot and midfoot surgery, for sure, you should use ankle blocks. In the ankle blocks, you can observe that we have two deep nerves, extremely important for midfoot anterior surface of the foot, and the tibial nerve is for the plantar aspect of the foot, for bones. Now, for skin is a little bit different because with these two nerves is the same a little bit. The deep peroneal nerve innervates just a small part in between the first and second tooth for cutaneous innervation, but the tibial nerve also innervates all the plantar part of the skin. So the tibial nerve is for all plantar part of the foot, bone and skin. And also, you have three superficial nerves, superficial peroneal nerve for the anterior part of the foot. So, once again, for plantar part, skin and bone, tibial nerve, for anterior or dorsal surface of the foot, is superficial peroneal nerve for the skin and deep peroneal nerve for the bones. If you want to operate at the lateral part of the foot, you should add a sural nerve block. If you want to operate to make the surgery at the medial part of the foot or ankle, you should organize a saphenous nerve block. So, what's the difference in between 5 nerve blocks, like an ankle, or just doing a spinal, or just doing eventually a popliteal or subgluteal nerve block? Look at this. This is a simple sciatic nerve block. And you can observe that it's extremely difficult to walk with this kind of block because it's difficult to fix the knee, and you have also a foot drop after a sciatic nerve block. Look after 1 hour after just an ankle block for foot surgery. It's just 1 hour after the surgery, and the person can walk easily without any difficulties. So that's why when you test ankle block, you never come back again to popliteal block or general anesthesia or spinal or what you want. It's so wonderful to organize and to make distal blocks for foot surgery, but once again is a revolution in the treatment and on anesthesia for foot blocks. So first block to organize is the tibial nerve block, just above the medial malleolus. Look at the tibial artery, and just beside a small nerve, but probably the biggest one of the 5 nerves, is the tibial nerve. Just in this, you inject 3 to 5 mils of local anesthetic, sometimes 5 to 7, in fact, because in this block, you will lose a lot of local anesthetic to localize the nerve, to make hydrolocalization. And for sure, with 3 mils of local anesthetic just close to the nerve or around the nerve, it's largely sufficient. But very often, you will see that practically, you will lose more volume, even if you need only a very small volume to anesthetize this nerve. Once again, look at this is the plantar aspect of the skin and plantar aspect of the foot bones. Second thing, deep peroneal nerve block. I just have to stop the discussion at this level. If you prefer, if you don't know how to organize, and if you're not sure of your practice, maybe because with these 2 nerves, deep peroneal nerve block and tibial nerve block, you can see that you will obtain a very good analgesia for a long-term duration using long-term local anesthetic, long-duration local anesthetic. You will obtain a good analgesia if you add some additives for 24 hours. So, but if you are not sure of your technique, you can either organize and perform a general anesthesia or a spinal anesthesia or a popliteal nerve block with a short-acting local anesthesia for surgery, and then long-acting local anesthetics for deep peroneal nerve and tibial nerve block. You will obtain a good analgesia for all bones. On the dorsum, you will look for the anterior tibial artery. Once again, another artery. So an easy block, in fact, very easy block. Just you come from your foot, pass the articulation, and look for the tibial crest. Immediately, just beside the tibial artery, you will perfectly see, and it's a very easy block, the deep peroneal nerve block. And so inject the same 3 to 5 mils of local anesthetic. Once again, sometime to localize the nerve, you will lose some mils of local anesthetic. That's why we frequently use more than 5 mils for this block. And so inject 3 to 5 mils of local anesthetics. And that's okay, very simple block. Just close to the nerve or encircle the nerve, doesn't matter, but close to the nerve is enough because they are very small nerves. Now, the 3 superficial blocks. The first, the superficial peroneal nerve block, once again for the anterior part of the foot, the dorsum of the foot, on the skin only, follow the fibula until you see 2 muscles. The extensor digitoris longus and the peroneus muscle, and then the fascia of the tibia. So 1 muscle, 2 muscles, at the intersection of these 3 things, the fascia, 1 muscle, 2 muscles just in front of the fibula, you will think at this intersection, the superficial peroneal nerve. Look at this, always here, 1 muscle, 2 muscles, the fibula, the fascia of the leg at the intersection of these 3 muscles, 2 muscles, and fascia, you will find always the superficial peroneal block. Once again, easy nerve, just control that the nerve is not already divided. That's why very often you will do it at the middle of the leg or at the beginning of the last third of the leg, but not so close to the malleolus. Now, if you want to operate at the lateral part of the foot, you should add a sural nerve block. So look at this for the first 5th 2, perfect, you need it absolutely, but also for the 4th one and also for the 3rd one. In fact, 3, 4, 5 2s, you should add a sural nerve block. So for only the 1st and the 2nd, you could organize the local anesthetic and without any sural nerve. How to organize, how to perform the sural nerve block? So very simple, just behind the Achilles tendon, you will perfectly see the sural vein, and very often you will see only the sural vein. And looking to the sural vein, just beside the sural vein, you will see extremely easily the sural nerve. Sometimes you will not see exactly the sural nerve, but you will always see the sural vein. So inject just beside the sural vein. One tips and tricks. The most important is to know that the sural vein is always at 0.5 centimeters from the skin and not deeper. So it's extremely superficial. And look at this, is the sural vein you inject, and immediately after the injection, you will see better the sural nerve. So it's not a complex block, but sometimes you will not see perfectly at the beginning the sural nerve, but immediately after 1, 2, or 3 mils of local anesthetic, you will see clearly the nerves, just injecting beside the lesser saphenous vein or the sural vein, namely also sural vein. Is it useful to use a saphenous nerve block for hallux valgus? In fact, as you can observe in this publication, only for 3% of patients, you need a saphenous nerve block for hallux valgus surgery. But in fact, usually we perform finally all the nerve, including sural. Also because at the beginning of the surgery, people are afraid a little bit when they feel something on their foot. So if you block all the nerve, they feel that the foot is really anesthetized in the under part. And if you don't block the saphenous part or the sural part, in fact, they will feel the skin at the lateral border of the foot or the inner border, the medial border of the foot, and they will feel that the nerve is not fully anesthetized, and they will be a little bit afraid. So, in my opinion, at the beginning, for sure, perform the 5 nerves, including saphenous nerve and sural nerve. So how to perform the saphenous nerve? Once again, simple block, 3 centimeters above the medial malleolus, very superficially. You will perfectly see the saphenous vein, and you will inject 2 milliliters of local anesthetic on one side and 2 milliliters on the other side of the saphenous vein. And the block will be made very constantly. So, like you can observe here, inject just on one side, then on the other side. You will always see the vein just at the border of the tibia bone, and it's simple to observe. So now, is it a good way to perform ankle blocks or to go directly to spinal or to go to popliteal nerve block for hallux valgus surgery? In fact, in this systematic review from Prospect of this year, in 2020, the recommendation is to use ankle block as a first option for regional analgesic technique. But I can observe also that, in my opinion, for forefoot and midfoot surgery, you can use as the first option also for surgery. Like this, you will have only one technique to perform surgery and analgesic technique. And wound infiltration can be also a reasonable alternative, but really it's fully different in between the two when you use the two. Now, what we use ankle block, we use the most ropivacaine, 0.375%. Only, it's largely sufficient. You never need 7.5% of ropivacaine, and you can add or 1 milligram per nerve or IV in the solution, or IV 8 to 10 milligrams of dexamethasone to increase the duration of the block. And as you can observe, for 100 patients, 0% of conversion to general anesthesia with only ankle block for surgery. Time of period of first recue of tramadol is for 24 hours, more or less. And then maximum pain was 2 on a scale of 2 of 0 to 10. So it's extremely interesting to use ankle block in hallux valgus ambulatory surgery. It changes all the procedure and it changes all your daily practice using ankle blocks for hallux valgus. Why? Once again, never forget this. In this case, you will not be able to leave the hospital and just you will need a breath, you will need somebody to help you to go to your car, etc. And here, 1 or 2 hours after the surgery, you go back to home without any trouble with ankle blocks. So the choice in this surgery is extremely simple. Thank you for your attention. I will give you the lead.
Thank you very much, Alain. Can you hear me? Yes.
We don't hear you.
Thank you for your excellent presentation.
I'm sorry, Paul, but I don't hear you.
Sorry, Maybe.
Mine.
No.
Okay, perfect.
Yes, now, can you understand me now?
Yeah.
Yes, okay. Thank you for this excellent presentation. And I will start with questions to your presentation. Maybe you can also use the question and answer button, but first of all, I have a question to you. When you do a popliteal block, Alain, you can do it at the level of the bifurcation, or you can do it a little bit more proximally. What do you prefer?
This is the worst question we can ask, because in fact, we just came from a new publication. No, new. In fact, it's not new, because if you remember, Jerry Voloka, 20 years ago, already made this publication explaining that you have two channels for each part of the block, the common peroneal nerve and the tibial nerve. So until proximal aspect, even in subgluteal, you can have these nerves divided. For us, we prefer to do it just above the publication, but we always control the diffusion of local anesthetic because we feel it safer. But if you want a shorter one set time, you could go down to the publication and look at the spread of local anesthetic in the two channels, one channel for the common peroneal nerve and the other channel for the tibial nerve block. And so you will obtain a better one set time and a shorter one set time if you can observe the local anesthetic spreading in these two channels and circling the two nerves separately. So the discussion is still open in between that. It's very difficult, in fact, to answer to this question. But for now, and for you, for example, what do you prefer, Paul?
It depends on the patient. Sometimes I do it at the level of bifurcation because we have a very fast onset. Sometimes I do it more proximally. It depends from case by case, yes. I have another question, Alain. You have showed us that 70% of your procedures are outpatients, ambulatory procedures. And you didn't talk in your presentation about catheters. Are you never using catheters in your hospital, or are there some indications where you say, okay, in these patients, we use catheters?
It's another terrible question, Paul. No, we use very few catheters, but it's particular in our hospital. And once again, it's case by case, because in fact, in my hospital, to organize a knee surgery, a total knee prosthesis is half an hour. We use a lot of adjuvants. If people are pain on the day after the surgery, we can block again just before they leave the hospital. So we prefer not to use too much catheters. But I fully agree that depending of the surgeon, depending of the institution, depending of the team also, because when you present the solution of the catheter at the consultation of anesthesia, you should be sure that all your team will perform the catheters. And it's a team question. It's not because in your team only one people prefer to use a catheter is not the good way. And as we know, it's extremely difficult for the teams, all teams, to organize catheters techniques and to go back home very quick, very fast at home with catheter. It's complex organization, but I fully agree that depending, it's not uniform. If the surgery is hard, if the patient could have pain for more than 2 days, for more than 48 hours, etc., yes, you should use a catheter. But you should understand that you should manage the whole technique and not just to say, okay, catheter is good and one of the guys of the team will organize the catheter. It's a whole organization, extremely interesting, but time consuming, cost consuming, and step by step, in 80% of cases, we don't need it. We need also, with adjuvant, you can organize the same situation. For example, I agree with you, the discussion is about knee surgery and particularly TKA. But for foot surgery, as you can observe, for example, observe that 20 years ago, we said for hallux valgus, we need a popliteal catheter, etc. But 20 years after, in the surgery, it's so simple now to organize an hallux valgus surgery in 15 minutes, very simple, one cut, and so simple, and people doesn't experience pain at all after 24 hours of peripheral nerve blocks. And if you organize just beside the multimodal analgesia, adjuvant, etc., in fact, you don't have so much rebound pain.
Okay, thank you. There's another question. A question regarding a patient removing necrotic tissue in a diabetic foot, but it does not heal and the patient feels severe pain. Which anesthesia is used to relieve the pain for the patient? Or which analgesic technique? What would you recommend?
Yeah. In this case, the discussion could be open to use a catheter, a popliteal catheter, of course, because you will increase the level of arterial circulation, and could be a good way for arthritic patient also, because it's sometimes in vascular disease, we use a popliteal catheter for that. So probably a popliteal block could be extremely interesting, and why not a popliteal catheter in this case?
And another question, a pregnant woman with ankle fracture. What kind of anesthesia for surgery with the least impact on the fetus? What do you recommend?
The same is peripheral nerve blocks, of course, as we all know.
Exactly. So now there are some questions. Very good. Some questions to me, some questions, maybe stay a little bit, maybe we have some more questions to you. So a question to me. There's a great risk of infections during tracheal intubation for surgical patients with suspected or confirmed COVID pneumonia. In order to effectively reduce the risk of infection, what interventions effectively inhibit airway secretions or create better conditions for intubation and extubation? I would say we have a high-level intensive care unit here in our hospital, and we have a lot of severe COVID patients, and nearly half of the patients also requires ECMO, extracorporeal membrane oxygenation. And I must say, we never had a transmission or infection of our staff in the ICU. I think the main reason, and this is my recommendation, you should wear the proper and the adequate personal protective equipment. That means you have to wear water-resistant gowns, you need to use your face shield, and you have to always use, we use in the ICU only FFP3 masks. And if you use these protections, I think you are it's very safe to work even with highly infected COVID-19 patients. So another question, let me go through the chat. Some question for you. Middle-aged, 42 years old, man with a right ankle joint surgery, anesthetized the lumbar vertebra 3 FE. Should the tube be placed upwards or downwards? I don't understand this question.
Yes, I understand, but for me, I will not use the spinal anesthesia. If I use it, I go down for sure. Because when you want to organize, when you want to perform a spinal anesthesia in between L3 and L4, you are very frequently in between L2 and L4 already, and L2 and L3, so go down. But in fact, the problem is not a problem, because we will perform a peripheral nerve blocks for ankle surgery, and we will not need to use the spinal anesthesia for that, because with peripheral nerve block, we will perform either the surgery and then the analgesic.
I think you are completely right. I think that this is what we see also in orthopedic surgery. We go away from central blocks towards the peripheral blocks. And because all the central blocks, you always block 2 legs, and usually you only have a surgery on 1 leg. There's another question during COVID-19 period. It's safer to choose non-general anesthesia. Absolutely. I think I have shown you in my presentation, if there is the possibility to use a regional anesthesia, you should prefer the regional anesthesia. And general anesthesia, but of course there are many surgeries where you cannot use a regional anesthesia, where you have to go to the general anesthesia. But again, what I said before, the right and the correct and the proper personal protective equipment, and then you can also do very safely and perform very safely a general anesthesia. I go through the chat if there is someone. There's a question to me, what regional anesthesia for upper abdominal or lap surgeries in COVID-19 positive patients? We do not change our procedure for upper abdominal surgery. You have to do, even if it's a lap surgery, you have to do it in our department with a general anesthesia. Maybe we would add in these tap lock or something like that, or maybe also if it's a major abdominal surgery, pancreatectomy, we would also add for a COVID-19 patient a thoracic epidural anesthesia for post-operative analgesia. So you see the anesthesia and analgesia regimen is not so different for many operations, especially for major truncal operations. There you will have no optimal choice, and you cannot concentrate only on regional anesthesia. So I think we have now 1.5 hours, and I think the time is over. And I would give for the closing remarks to Charlie. First of all, I would like to thank my friend Alain for this excellent presentation. And please, Charlie, I think you will give the closing remarks.
Yeah, thank you, Professor Paul Kessler and Professor Ellen Dalbas. So welcome all the audience to our Surgical Line College Global Webinar. To attendees who participate in all of the 6 webinars in the meeting with expert in regional anesthesia series, we will grant a special certificate with signature of experts. Stay tuned with us. So let's say thank you, both of professors again, and also many thanks to all of the audience who are with us today. So it's time to say goodbye. So wish you all have a nice day. Please follow our Meet with Experts in Regional Anesthesia series agenda. We have totally 6 webinars, also 5 left in the 14 days. So please follow us in Facebook, LinkedIn, and many other social medias. So see you again.
Thank you.
Thank you very much.
Bye bye. Bye bye.
Bye
bye. Yes.
Yeah.
Bye bye.
Bye bye.
Have
Excellent.
nice.
Excellent.
Thank you, Charlie.
Thank you, Charlie.
Thank you. Bye bye.
Thank you again. Are we now with us, or are we together now?
Yeah, seems to be.
Yes. So.
Oh.
we had many other questions, but I think time is running, and it was not enough time to answer all these questions. Yes.
Yeah. Yes. Maybe next time we arrange another like series of webinars in the future.
Okay.
Thank you so much. You have done a really excellent job, both of you. Yeah. Very illustrative graphics and videos from Professor Ellen Dalbas, and also very explained and very useful messages from COVID-19 patients, dealing with COVID-19 patients from Professor Paul Kessler. Yeah. So thank you very much. See you again.
Thank you. So I will, see you again. Bye bye. Bye bye.
Bye bye.